Okay, I think we're going. I'm pretty sure we're going. I'm gonna make sure we're going. And then I am just not the epitome of Zoom um navigating. That is all. Okay, we're good. We're going. We're going. And let me get these slides. Let's see here. Okay. We have the slides. And we're going. I'm so sorry, you guys. Okay, hey, welcome back to part 4 of 5 in our chronic disease series. We've already covered cholesterol, metabolic dysfunction, and inflammation. So, wow, that's a lot. You're like, what more could we possibly talk about? Oh, but wait, there is more. And tonight is one I actually get asked about the most. And in my opinion, it's because it's the one that scares women more than any of the others. So tonight we're going to talk about cognitive decline. And here's the good news. The most recent Lancet Commission update from 2024 says that up to 45% of dementia cases could be prevented or delayed by addressing 14 modifiable risk factors. 45%. That means this does not have to be inevitable, okay? If we start early, we can absolutely do something about this. But the bad news is that most of the work to protect your brain, and it might not even be bad news. Honestly, the good news is that most of that work to start protecting your brain happens in your 30s and 40s, right? Not in your 70s. So a lot of you guys here today are hopefully 30s, 40s, maybe even in your 50s, and you have some time. Okay. So by the time someone is like sitting in a neurologist's office getting a diagnosis, that is like not the best time to start, but it is the second best time to start if that's where you're at. Okay. But by the time you get a diagnosis, disease and pathology have been building in your brain for 10 to 15 years or even a little bit more. And we just like do not want to wait for a diagnosis on this one, okay? We want to absolutely catch it in the gray zone before symptoms appear. And tonight, my goal is to equip you with the knowledge and tools to give yourself the best edge to prevent this from happening to you. So here we go. As I kind of briefly stated in the intro, when most people picture cognitive decline, they see like their 75-year-old grandparent who suddenly starts forgetting names and getting lost at the grocery store. But that picture isn't totally correct. Okay. And it's why most women listening to this might not be protected because you didn't realize there were a lot of things that you could actually do about it ahead of time as long as you started early enough. So cognitive decline does not start in your 70s. It starts in your 30s. And by the time, again, I'm going to stress this point, by the time someone is symptomatic, that pathology has been accumulating for 15 plus years. So let's look at the stats. I have my two stat boxes here. 2 out of 3 Americans with Alzheimer's are women. Not because women live 5 years longer on average, even though that's kind of part of it. The biggest reason is that the conditions driving Alzheimer's hit women's biology harder. And as you can see in the second stat box, 1 in 5 women over the age of 65 will develop it. The reason you can carry damage for over a decade without noticing is because of something called cognitive reserve. And I want to talk about that a little bit. So think of this as your brain's buffer. It's made of 3 things: the strength of your neural connections, the redundancy in your brain networks, meaning if one pathway slows down, another one can kind of pick up the slack, and your brain's metabolic flexibility, which is basically the ability to keep generating energy when one source isn't working well. If you have a generous reserve in all 3 of these areas, then your brain can absorb damage without symptoms showing up. And you can have a brain that is measurably accumulating disease, but still kind of seems completely normal at the dinner table. And as that reserve narrows, especially in perimenopause, it doesn't totally disappear, but it narrows. And when it gets thin enough, the accumulated damage, it starts to show up. This is when the symptoms emerge, right? Brain fog, the word finding issues, missing appointments, all of these things that you kind of like might really scare you in perimenopause. And the reason they're showing up in perimenopause, that doesn't necessarily mean that you're gonna get Alzheimer's just because you're experiencing those things. It's just because at that time, and you see these kind of three risk factors here, why women are significantly higher risk, is because that is the window when you're precipitously losing that estrogen, right? And estrogen is neuroprotective. So when we lose it rapidly, then some of these symptoms can kind of pop up in midlife. It doesn't mean that you are necessarily at higher risk or that you're going to get it just because of this time frame. However, it is an additional risk factor for women and one reason why women are at higher risk. Okay, so there are three reasons, not just the estrogen, even though some of them, and I would probably largely guess that most of them do have to do with losing our estrogen. Right? They all three really kind of trace back to estrogen and our specific biology. Okay, that first one, like I said, estrogen is one of the most powerful neuroprotective molecules your brain has. It supports your neurons, it regulates neurotransmitters, it controls inflammation in the brain, and when estrogen drops in perimenopause, your brain loses one of its biggest tools for that buffer. And that's why we kind of see this cognitive cliff in women in their late 40s and 50s, that brain fog, the forgetfulness, the word finding issues that come on suddenly and feel scary. Secondly, the major risk variant genetically for Alzheimer's is called ApoE4, and it hits women harder than it hits men if you have one or two copies of this thing. Now, there's a common misconception that women actually carry this genotype or this, at least one copy of this gene more often than men do, but that's not actually what the data shows. In a landmark paper by Altman and colleagues in 2014, in the Annals of Neurology, they specifically looked at this. And what they found was that men and women actually carry the ApoE4 genes roughly at equivalent rates, but women who carry one copy are nearly at twice the Alzheimer's risk as a man who carries one copy. So the carrier rate is the same, the effect size is what is different. So when we say ApoE4 hits women harder, we mean that the same gene in the same dose does more damage in the female brain. And we're still kind of trying to figure out exactly why that is. It likely involves how ApoE4 interacts with estrogen withdrawal, with different things that can also contribute to dementia and Alzheimer's, like tau protein accumulation in the brain and with brain insulin signaling. But the effect is real and well documented. We just don't understand the full underlying mechanism. And then third, estrogen also regulates your brain processing insulin. Your brain runs primarily on glucose, right? So that is like basically blood sugar. So like when we eat carby goodness things, fruit, all of that stuff, our body has blood sugar, we have glucose, and that is going to power our brains. That's going to power most of the cells in our body, including our neurons. And insulin signaling tells your brain how to take that glucose in, how it crosses essentially the blood-brain barrier. And when estrogen drops, brain insulin signaling gets worse, and your brain literally has trouble getting energy from glucose. This is why brain glucose metabolism measurably declines during menopause, the menopausal transition. So researchers like Lisa Mosconi, she's a famous perimenopause, menopause researcher and clinician. they have demonstrated this exact thing on PET scans. So when I say women carry more of the cognitive risk burden, I'm not making a vague statement. I am pointing to three specifically and well-documented mechanisms in peer-reviewed literature. And the work to address all of these needs to start now, not at age 65. And if you're 65 already, then again, the work needs to start now, right? Not waiting 5 to 10 more years. So these are the 7 numbers we should focus on when it comes to dementia and dementia risk. None of these are part of a standard physical. None of them, 0. Like on the other ones, we had like a few, right, that were on a standard physical. These, none of them are. And we've talked about some of these before, but I'm gonna reflect what they mean as it pertains to cognitive decline in this presentation. So again, none of these are on that standard physical, but also none of them require permission from your doctor to think about. And also there's like self-order that you can get now. You can reach out to me and we can make it happen. Okay. Together, these all are going to give us a picture of your brain risk 10 to 15 years before any imaging or memory test would actually catch a problem. That sounds like a good idea, right? Absolutely. And again, the goal here, like, isn't to scare you, it's to give you actionable data while you actually have time to use it. So we're going to go over these one by one. We've seen some of these in previous presentations. So number one on the list for neurocognitive decline is homocysteine. This is a marker of vascular damage. It's an amino acid your body makes when metabolizing protein. And when you have healthy methylation, or you're able to like utilize B12 and folate and B6 to kind of do this DNA methylation, we are going to see homocysteine being relatively low when we are methylating well. Okay. But when that methylation process kind of breaks down, homocysteine accumulates in a higher amount and can become neurotoxic. So high homocysteine actually damages the inside of the lining of your blood vessels, and that we do not want can increase your risk for obviously all-cause dementia, okay, especially Alzheimer's. So over 20 years, that damage can show up as small vessel disease in your brain. This is how it works. And small vessel disease is one of the top contributors to vascular and mixed dementia in women. So the Framingham study in 2002 found that homocysteine above 14 was associated with roughly 2 times increased Alzheimer's risk over their follow-up window. And the target is under 8. And we'll go over targets for everything on the next slide. I just happen to mention them here because of the study. So concerning is above 12 and high risk is above 14 homocysteine. So here's the actual exciting part. David Smith at Oxford ran a trial called VitaCog, VitaCog, all caps. And it was published in 2010, and they gave adults with mild cognitive impairment high dose B12, just like vitamins, right? Folate and B6 over 2 years. And that treatment group had roughly 30% less brain atrophy than the placebo. And the subgroup who started with homocysteine above 13, brain shrinkage was reduced by up to 53%. That's awesome. There is nothing in the pharmaceutical pipeline that comes close to that effect size with the safety profile at that cost of just a nice B vitamin supplement. All right, that's really cool. So it is one of the most underutilized markers in medicine, homocysteine is, and you have to actually ask for it. Specifically, most clinics, most practitioners will not draw it. So number 2, HSCRP. This has been in every single presentation, right? So it's like, why don't we just add this to the normal panel? I don't know. Um, so this is not standard CRP your doctor usually orders. Standard CRP catches active infection, really heavy inflammation burdens. HSCRP catches the chronic low-grade inflammation that can drive a lot of things, right? Everything that we've talked about up until this point. Um, Heart disease risk, inflammation risk, diabetes, and metabolic risk, but also Alzheimer's pathology. So Schmidt in 2002 in the Annals of Internal Medicine showed that chronic elevation above 3 milligrams per liter was associated with increased dementia risk. So we need to ask for HSCRP, right? The high sensitivity assay specifically. Number 3, we talked about this one 2 weeks ago, HOMA-IR, the insulin resistance calculation. So fasting insulin times, this is the calculation, fasting insulin times fasting glucose divided by 405. Joseph Kraft did over 14,000 oral glucose tolerance tests showing insulin dysfunction precedes glucose dysfunction by 10 to 20 years. And brain glucose metabolism also measurably declines during the menopausal transition per what we talked about with Lisa Masconi's PET scan work at Cornell, right? So HOMA-IR is going to be a calculation that will predict insulin resistance about 20 years before, 10 to 20 years before your A1C will actually capture it. So I'm going to say it again so you guys know how to calculate that. I also have a video on this if you kind of go back and scroll through my Instagram. Or just shoot me a message or a DM and I can send you that video specifically. But it is fasting insulin times fasting glucose divided by 405. So what you would want to ask for is a fasting insulin and a fasting glucose, and then you can calculate this on your own. Or you can just ask for a HOMA-IR, and they'll do this for you, but they might not give you the pieces of the puzzle, which are also valuable. Okay, number 4, vitamin B12. Yeah, we talked about vitamin B12, right? So if this is low, it might not drive methylation as well, and then homocysteine might end up being high. So therefore, low B12 can cause cognitive symptoms, forgetfulness, confusion, mood changes, and those things, if your vitamin B12 is low, can actually just closely mimic dementia. But this is one of those causes of reversible dementia, reversible cognitive decline. And standard lab ranges are just too generous, or not generous, whatever the opposite of that would be, too stingy. A functional optimal here is 500 to 900. And if you've been on long-term proton pump inhibitors like omeprazole or something like that, generally prescribed for heartburn, or if you're a vegetarian or vegan or have any gut absorption issues, you can be functionally deficient while your labs still call you normal. Okay, number 5, vitamin D. In this study in 2014, it showed that vitamin D deficiency, which would be defined in this study as under 25 nanograms per milliliter, was associated with roughly 2 times increased dementia risk. Important caveat here, this is observational data, not causal, but the correlation is pretty strong here. So we definitely want to aim for a vitamin D of 50 to 80 nanograms per milliliter. And number 6, omega-3 index. And we've talked about this one before as well. Percentage of EPA and DHA in your red blood cell membranes. So in a study, again, in 2014, different study, postmenopausal women cohort showed lower omega-3 index correlated with smaller brain volumes on MRI. Whoa, that's wild, right? So we want to target omega-3 index to in range, and we'll talk about in range on the next slide. All right, number 7, ApoE genotype. And we've talked about ApoE a little bit, and we're going to talk about it even more throughout this whole thing. But this is not a target you can necessarily optimize, right? You can't change your genes, but knowing your ApoE status changes how aggressively you might want to address the other 6 of these markers, and how aggressively you might want to attack all of these levers that we're going to go over here in a little bit. So ApoE carriers have 2 to 3 times increased Alzheimer's risk with 1 copy of this gene, and 8 to 12 times with 2 copies. And I've heard them state up to 15 times increased risk if you have 2 copies. And your coach here, has 2 copies, which I think is part of the reason why I started this whole journey for myself and started this whole company, because I've had to be, and I've chosen to be, very aggressive with my lifestyle modifications, and it has made a lot of difference in my life while I've been young, and I wanted to share that with other people as well. And I want to definitely try to hedge all of my bets against Alzheimer's as I get older. I do not want to go down that path if I don't have to. All right, and we'll come back to ApoE4 here in a few slides as well. Okay, so that's the panel. If your doctor hasn't ordered any of this, you can ask. You could do ApoE4 through either a saliva test, you like spit in a thing, or you could do a blood test as well, and they can find it that way. If your doctor will not do this for you, like I said, you can do self-order. There are plenty of places out there that will allow you to do self-pay and get these on your own. And again, you can reach out to me and we can get this stuff done as well. Most insurance will cover some of these things, especially if you have a family history of dementia. Okay, so these are numbers you can actually change with the right work. And these are the targets that we're going to aim for here. We're just going to go over these quickly, okay? So these are not, again, standard lab reference ranges. These are optimal targets from precision medicine and functional medicine ranges. So same story with vitamin D. Homocysteine, we went over this. We want to target under 8. And we're going to start to worry above 12. And if you're above 14, then we're like, yikes, right? That's high risk. All right. And then I have these out of order in my notes, which is hilarious. So HSCRP, we want to target under 1, and we're going to start to worry above 3. And then HOMA-IR, we want it to be under 1. That means you're insulin sensitive. Above 2 is concerning. And then if it's over 3, then we're like, ooh, like, let's do something about this stat, right? If it's above 2, I would argue also, let's do something about this stat. Also keep an eye on your fasting insulin, and the target is going to be under 7 for that one on its own. Vitamin B12, we mentioned it before, but 500 to 900 picograms per milliliter. Below 400 is functional deficiency, even though a normal lab reference range is going to capture that as normal. So keep that in mind. Vitamin D, 50 to 80 nanograms per milliliter. If we're under 30, we need to worry. If we're, under 40, then we should probably still treat this. But I would definitely, before you take vitamin D, I would get tested so we can actually figure out a dose that's appropriate for you. This is a fat-soluble vitamin that you can overdo. All right, omega-3 index above 8% of red blood cell membranes. That's what we want. Below 4% is high cardiovascular and cognitive risk. And then just taking EPA, DHA fish oil is going to be the thing that we do for this. And then we can titrate to dose if we know what your omega-3 index is. If not, it's pretty safe to say you can take 2 to 4 grams a day of EPA, DHA fish oil. Okay. ApoE. This isn't a number you can chase. It is a number you cannot move. But knowing yours can tell you, again, how aggressively to chase the other 6. And we'll talk about it more here in a little bit. So as with every other presentation on chronic disease that we've been through, all these other deep dives that we have done, we have this lockstep approach, right? And we're going to start with rung 1, which is going to be lifestyle levers. Rung 2 is nutrition levers. Rung 3, supplementation, and rung 4, which is going to be medical interventions. The most important thing about this ladder is that most of the work for brain health is at rung 1 and 2. Then the supplements can help, and the medications can help in the right cases, but neither of those replaces sleep, movement, food, and managing stress. Okay. So anyone selling you a brain supplement without addressing the foundation is selling you hope, not science. Most of the movement and most of the actual work is done here in rung one and rung two, even if you want to also add stuff from the higher rungs. That's why we're starting at the bottom of the ladder with lifestyle. Okay. So this is, like I said, where the biggest gains happen, where you can hedge your bets the most against cognitive decline. And we'll go over each one of these. So sleep is absolutely non-negotiable. Your brain has a cleaning system. This is crazy because it sounds like a made-up word, but it does. It has a cleaning system, and it's called the glymphatic system. It kind of like it kind of reminds me of like glamping or glamour. So you want to get your glamour sleep and activate your glymphatic system. So your glymphatic system runs almost exclusively during deep sleep. It physically washes out any like debris and any kind of like, gosh, anything that's going on in there. This is like your scrubbing cleaning system, right? It'll wash out any beta amyloid, which is one of the proteins that can accumulate in Alzheimer's, and it can like scrub those out of your brain tissue. So one night of poor sleep can raise debris and amyloid measurably by the next morning. And the I'll sleep when I'm dead decade will catch up with you here hard, right? So targeting 7 to 9 hours of sleep and doing all of the sleep hygiene stuff to ensure that you're maximizing your deep sleep, which tends to get lower and lower and worse as we age, is going to be absolutely key here. I'm not going to go into like all of the things and all of the sleep hygiene stuff right now, but if you're curious, go ahead and reach out to me and ask me for my sleep handout, and I'll give it to you, and it's going to go into detail with all of that stuff. Okay. So strength training 3 times a week, just like everything else. So it's like, hey, a lot of this stuff overlaps, right? So it's like, oh, like, shoot, I could kill all of the birds with most of these stones, which is the best news ever. You're not just like adding all of this crap for this and for that and for this. Like a lot of this stuff really overlaps, right? You're going to help your inflammation. You're going to help your blood sugar. You're going to help your cardiovascular risk, disease risk with these same things. So strength training is one of the strongest interventions for cognitive longevity. It increases a neurotransmitter called BDNF, or brain-derived neurotrophic factor, which is one of your brain's growth signals. It preserves gray matter measurably on MRI in trained adults, which is freaking awesome. Then zone 2 cardio, 150 minutes a week minimum. This is cardio where you can still hold a conversation, but you can't sing, or you can exercise, but like someone would know you are working out. Multiple studies show 30 to 40% reduction in dementia risk with consistent aerobic activity. Another good one is sauna, 3 to 4 times a week. The Finnish data is actually extraordinary on this. People who use sauna 4 to 7 times a week, that's crazy. It must be nice. You must have a sauna at your house if you're in it 7 times a week. But these people who do that 4 to 7 times a week have 65% lower dementia risk than people who use it once a week. Whoa, so it's like multiple times a week is better. The mechanism is that these heat shock proteins that we have give us a cardiovascular benefit and a beneficial circulatory effect, and it can probably help us, right, clear some of that debris out of our brains. Stress management, this is a big one, guys. Chronic elevated stress can elevate our stress hormone, cortisol, and this can, over time, shrink this part of our brain called the hippocampus measurably. Not metaphorically, but actually physically shrink it. Okay? So we need to pick whatever works for us to preserve that part of our brain. So meditation, breath work, time in nature, therapy, being around your community, your friends, having that deep connection with others, the mechanism of how you do this matters less than actually being able to manage that stress. Okay, and then social connection. These two I do kind of think goes hand in hand. But loneliness raises dementia risk comparable to smoking, which is kind of crazy. So, like, we are just social animals. We're social mammals. And isolation drives inflammation and also raises cortisol. And then hearing protection. This is the biggest one that most people miss. Untreated hearing loss is the largest modifiable midlife risk factor for dementia. And that is per the 2024 Lancet Commission. So if you can't hear well, your brain is going to stop getting auditory inputs, and the auditory cortex is going to shrink and cognitive decline will accelerate. So get your hearing tested. And if you're having trouble, get the hearing aids and freaking just wear them. It's going to benefit you on so many levels. And vision care also was added. Same logic as the hearing. So if you can't see well, don't just power through it, address it. One more thing that I want to talk about with lifestyle is enriched environments. A lot of these, like Alzheimer's and dementia and cognitive decline researchers, will talk about these things called enriched environments. And then you're just kind of like read that on thing, you're like, oh, cool, be in an enriched environment. What the hell is that? Well, I'm going to tell you right now. This is a concept from neuroscience research. Your brain literally grows new neurons and synaptic connections when you put it in environments that demand novelty, complexity, social engagement, and physical movement. And this is how you build cognitive reserve, that buffer we talked about earlier. So practically, this means things like learning a new language, learning a new instrument, taking a dance class, which that one's good, like even an instrument too, because it kind of like combines physical movement with social interaction and cognitive demand all at once. Traveling is a good one, taking on some kind of creative project, engaging in real conversations with people in real time. All of these things would be considered an enriched environment. So learning a new skill that you're bad at, which hopefully, like all of us are kind of bad at stuff when we're first learning, right? And that's the point. The discomfort of being a beginner at something is exactly the signal your brain needs to grow. So what enriched environments do not include, just in case you were wondering, death scrolling, passive television, repetitive tasks at work that no longer challenge you. Comfort kills cognitive reserve. Novelty and complexity build it. So build that reserve. And you can always build this reserve, I would argue. Like, it's not just even while you still can. Just continue to learn, continue to challenge yourself mentally. Okay, nutrition lovers. Rung two, the foods that feed your brain and lower inflammation. And we've talked about a bunch of these last week as well. But omega-3 rich foods makes all the lists, right? Fatty fish, 2 to 3 times a week. Wild salmon, sardines, mackerel. We call it smash fish. These are just like lower mercury containing fish that are high in omega-3s. So smash is sardines, smash, mackerel, sardines, mackerel, anchovies, smash, salmon, herring, smash. You got it. If you don't eat fish, walnuts, flax, chia, those are also high in omega-3 if you don't eat fish. Okay. DHA is the most structurally important omega-3 for your brain cell membranes. So you know that I've been talking about having a supplement that has both DHA and EPA in it. So DHA is the one that you're specifically looking at for brain health, but you want both. So B vitamin density, leafy greens for folate, eggs and animal proteins for B12, liver is gonna, yeah, I know I said it, liver is gonna be really, really super high in B12, legumes and whole grains for B6. This is the food layer of homocysteine that we worked already. But also choline is going to be a big mover for methylation in some people. So just Google choline-rich foods, and some of these are the same as B12-rich foods as well, eggs, liver, stuff like that. Polyphenols, berries, dark leafy greens, extra virgin olive oil, green tea, dark chocolate, all the good stuff, right? These are all anti-inflammatory and directly neuroprotective. Continuing to keep stable blood sugar. Glucose variability, especially high spikes of blood sugar, can damage vasculature over time. So spikes and crashes are also inflammatory. So trying to manage your blood sugar and continuing to keep it stable. Protein at every meal, 30 to 40 grams for women, over 35. And really, I would argue most people probably need that. Your brain needs amino acids to make neurotransmitters and support repair, and to support hormones as well. The mind diet pattern. Whoa, what's that, Stevie? This is an eating pattern that has shown strongest direct evidence for brain protection, and it's a Mediterranean DASH diet hybrid. So if you can imagine, Mediterranean diet has a lot of omega-3s, rich in omega-3s, right? And then the DASH diet is like for people who have high blood pressure. So as you can imagine, elevated blood pressure would be a negative for Alzheimer's risk if you have it. And then some people don't need this because their blood pressure is actually low. So this is going to be a case by case basis for sure. But this mind diet is the Mediterranean DASH hybrid, and it's built around 10 brain healthy foods. I don't know what they are. I actually didn't get that far. Sorry. I will find that for you guys later, and I will make sure that you have access to that. I was running out of time building this before I had to teach. So, but people who follow this strictly cut their Alzheimer's risk by about 53%, which is pretty freaking good if you ask me. So even moderate adherence to this diet cut it by about 35%, and that's a big effect. That's a bigger effect than most pharmaceuticals. And then two bonuses that didn't make this slide quickly. Fiber. We can't have a presentation without talking about fiber, right? So 25 to 35 grams a day, and I would argue let's aim for the high end, so 35 plus. This is more important than people realize always. Fiber feeds gut bacteria that produce short chain fatty acids, and those acids are anti-inflammatory, and they're going to protect the blood-brain barrier and the gut-brain axis. And then alcohol, we are always talking about this too. This is the one I want everyone to freaking hear, okay? So more than 7 drinks a week for women measurably shrinks your brain on MRI. It's not a glass of wine a day is heart healthy anymore. Like the data has moved. Alcohol is neurotoxic, period. It disrupts sleep, it drives inflammation, and it accelerates brain atrophy every single time. So cut it down. You don't have to be perfect. Just let's, over time, aim for less. Again, as an ApoE4 person, I have cut it out completely because it just does not serve me anymore. And it never probably did to begin with. Okay, supplementation levers. This is rung 3. Targeted, we want to keep these supplements targeted based on the labs that we talked about earlier. We don't necessarily want to just do this because there was some influencer on the internet selling them, okay? So what are these and why do they help? So omega-3, EPA, and DHA, 2 to 4 grams a day is going to lower neuroinflammation and support brain cell membrane integrity. Get a third-party tested triglyceride-based fish oil, not just whatever is on the shelf at Costco. Although I did look up some Costco ones the other day, and they did have a couple that fit this bill here. I would be careful at like Kroger or Safeway, probably, though. They do all usually have a brand called Nordic Naturals, which I use personally and does actually check those blocks. Okay, creatine. So the standard dose for muscle protection and for growing muscle is going to be 5 grams a day. And that dose does show some cognitive benefits, but the research is shifting a little bit. Your brain has lower creatine transport capacity than your muscles. So muscles always saturate with creatine first. And to fully saturate your brain creatine, especially in vegetarians and vegans who have lower baseline brain stores, or anyone who is chronically sleep deprived, the studies show that the strongest cognitive effects is 10 grams a day, using 10 grams a day, which is actually what I'm doing right now. I started doing 10 grams a day probably 2 or 3 months ago. I've been tolerating it really well, and I haven't stopped. So some sleep deprivation studies have even used up to 20 grams a day for like short-term bursts to kind of help you out. The Forbes 2024 meta-analysis shows that creatine improves short-term memory and reasoning, especially in sleep-deprived adults. It's one of the most well-studied and safest supplements in existence. And this is my practical take. If you're using creatine purely for muscle, 5 grams is fine. If you want the cognitive benefits, especially if you don't eat red meat or if you don't sleep really good, I might consider pushing to 10 grams a day and seeing if you tolerate it well. People who don't tolerate it well, some people get bloated, some people can get a little puffy. And if that bothers you, then we might want to back it off. Always, always, always make sure that you're drinking plenty of water when you're taking creatine, especially if you're taking 10 grams, because what is happening is your body is pulling water out of your kind of like vasculature out of your body into your muscles. So you need to make sure you have enough to hydrate you as well. Okay. And a lot of times when people have that bloating and all of those GI side effects from creatine, and there can be some other outlying side effects that creatine can cause, a lot of those are probably caused due to not drinking enough water in conjunction with the creatine. So creatine monohydrate is the most studied form, and it's the cheapest. So that's just what I would use. You don't need to take any fancy creatine, okay? Just creatine monohydrate. There's no evidence that any of the other fancy forms work any better. So you can take it at any time of day. You can take it with carbs and protein to enhance uptake. And you do not need like a loading dose or anything like that if you hear people talking about that. Brain stores will build over 4 to 6 weeks of taking it daily, just the same dose every single day at the same time. Vitamin D, dose based on labs, like we talked about earlier, typically 2,000 to 5,000 IU, international units, depending on what your labs say you're at right now. Aim to get your serum levels between 50 and 80. And then methylated B vitamins, if your homocysteine is high, this is your tool. Methylfolate or methylcobalamin. Okay, not the standard B complex from the grocery store. Although if you can get one that also has a little bit of like a complex in it, some B6, some folate, that might not be a bad idea. But get the methylated forms. These work for the majority of women, especially those with the MTHFR gene variants, which we'll talk about at the end. So magnesium L-threonate, 1 to 2 grams a day. This is the form that actually crosses the blood-brain barrier, right? This is going to support cognition and sleep. So magnesium glycinate is also great for sleep specifically, but doesn't specifically cross the blood-brain barrier. So pick your poison, 3-and-8, a little bit more expensive, generally speaking, but can have a little bit maybe more cognitive support. Curcumin with piperine, 500 to 1,000 milligrams. This is anti-inflammatory, and there's some evidence for amyloid beta protein tangle reduction in the brain if you have some of that going on already. Then we have like lion's mane, 1 to 3 grams a day, might promote nerve growth factor. There's just like emerging evidence on this, so I'm cautiously optimistic, but not like something I'd like rush out and prioritize at this time. So quick note on supplements in general. Again, none of these replace lifestyle and nutrition. They are a catalyst when the foundation is solid. If you're not sleeping, you cannot supplement your way to a healthy brain, period. We need to try to find a way to fix that sleep. All right. Rung four, medications. I'm going to brush through these as quickly as I can, just so you have some awareness. Um, this is a slide where I have to be the most careful because some of these are tools that can help. All right. And some of these are on an actively avoid list, or some of them are like, it depends. So we're going to talk through each of these specifically. First, the medications here I'm going to list are going to be helpful in the right person. Okay. So HRT, hormone replacement therapy, estradiol with or without progesterone, depending on if you have a uterus or not, started within 10 years of menopause. The data is overwhelmingly positive for cognitive protection when it started in this window. So earlier, the better once that estrogen starts declining. The Women's Health Initiative studies scared a whole generation of women out of HRT. The newer interpretation is much more nuanced. If you're in the window and your overall risk profile fits, this is a conversation worth having with your provider, okay? For some women, this may be one of the most powerful cognitive longevity tools that we have. GLP-1s, like semaglutide or tirzepatide. There's some actual emerging data on Alzheimer's prevention here, guys, beyond weight loss. These medications kind of appear to reduce neuroinflammation and improve brain glucose metabolism. All right, that's great, right? There's a major trial that's currently running. If your metabolic markers are elevated and you're a candidate, it might be worth checking out. But some promising data potentially for Alzheimer's in, again, the right candidate. Metformin. Metformin, another diabetes medication here. It activates a pathway in your body called AMPK, which has an anti-inflammatory effect. Observational data shows lower dementia rates in metformin users. And this is increasingly being used off-label for longevity. But again, I am kind of cautiously optimistic here. So I wouldn't necessarily be like, I need metformin for dementia prevention. I'm not there yet with this one, but potentially in the future if we have a little bit more data. But certainly if you're diabetic, this is a good place to start and can potentially be protective for you, especially if you're type 2 diabetic. Again, a lot of the research, I think I said this 2 weeks ago, a lot of the research coming out of this longevity study from metformin is like kind of showing this has a longevity benefit in people who are diabetic, but not necessarily in people who are not, which kind of makes sense, right? Okay, blood pressure medications. Controlling hypertension in midlife is one of the strongest dementia preventions that we have. We want to target under 130 over 80. And actually, everything kind of just went down a little bit. So if we can get even under 120 over 80, then that's even better. But whatever class of kind of blood pressure controlling medications gets you there, that's where the brain benefit is. So we want to get you down into that normal range, which would be considered like 120 or around maybe 70. We don't want you hanging out too high for too long. All right. And then we're like, ooh, SSRIs, SNRIs, treating depression. This is interesting. So really, untreated depression in midlife is a significant dementia risk factor. And treating it can reduce that risk. And like I said, in the right person, for a time period, if you need it, then I wouldn't be ashamed at all of getting on this thing and kind of let this help you out. It's okay. It's okay. Treating sleep apnea, right? It's like, do you have sleep apnea? Number one, women can present a little bit differently than men, may not have like those typical signs of like snoring loudly, a big neck. We can present a little different. So it's like, do you have it? Number one. If you have suspicion, if you just like have this daytime sleepiness that you can't quite shake, you don't really understand, you feel like your deep sleep is just like a piece of trash, or waking up at night and you don't really think it's like anything else, maybe it's worth getting tested because treating sleep apnea is going to help you tremendously. Untreated sleep apnea is one of the biggest dementia drivers that nobody talks about. If you've ever been evaluated and you snore, right? We talked about how maybe that's not going to be like a big predictor for you as a woman. But if you're tired in the morning, you're getting headaches, especially headaches first thing in the morning, you've gained some weight, or you notice that like your partner's like, hey, you do stop breathing at night, then we should get you a sleep study. We can facilitate that on my end, or we can go through your primary care and you can go sleep somewhere. They're getting a lot better about some home tests too. So the one I do is a ring that you'll just wear for 3 nights, and it'll tell you if you have sleep apnea, what type it is, if you have any other kind of sleep disorders, and it's going to evaluate your sleep on every other level to like help optimize it as well. So it's actually pretty freaking cool because going and doing a sleep study in clinic, just doing a polysomnography in clinic is what they would call it, isn't going to give you all those cool things and help you optimize your sleep. And that way, even if you didn't have sleep apnea, you would just be told, sorry, you don't have it. Or good news, you don't have it, right? Because you don't necessarily want to have sleep apnea. And if you do have it, we absolutely want to treat it. Okay, now these are the medications that we want to kind of be careful with. And statins are very nuanced here because for people with high cardiovascular disease risk, particularly elevated ApoB or elevated LP little a, which we talked about in the cholesterol and the heart disease number, like on the first week, the deep dive on the first week. If you haven't watched that one, go back and watch it. But if you have these elevated, statins have an anti-inflammatory effect that benefit the brain. All right. So for people with that risk profile, without that risk profile, though, which I would be like, hey, why are we giving it to them anyways? It's less clear cut. Even people with that risk profile, but with potentially some other risks, it might not be that clear cut. So the conversation should be patient specific each and every time. So lipophilic statins like simvastatin and atorvastatin cross the blood-brain barrier more readily than hydrophilic ones like rosuvastatin or pravastatin. And some patients report cognitive side effects with the ones that do cross into that blood-brain barrier. And there's a marker called desmosterol, a cholesterol synthesis intermediary that some longevity-focused practitioners measure before deciding on a statin in higher risk people. So if desmosterol is already low, a statin can further suppress cholesterol synthesis, including in the brain, which has to make all of its own cholesterol because it can't import from anywhere in the bloodstream. So for those patients, non-statin LDL lowering option, like ezetimibe may be a better fit. Statins can also slightly worsen insulin resistance, potentially. The right approach is really patient by patient, with ApoB measured, family history considered, ApoE status known, and overall risk weighed. So this is not an everyone over 50 should be on a statin situation. This really does need to be a case-by-case situation. If you're super duper high risk for Alzheimer's already, I might bring that into the conversation. All right, PPIs. The acid blockers like omeprazole and esomeprazole are like using these things long term, meaning like 4 years, can block the gastric acid you need to actually absorb B12. Low B12 causes cognitive symptoms that look like dementia, and long-term PPI use has also been associated with higher dementia risks in some observational studies, right? Because you can imagine it would also affect kind of some of that methylation status in some people and increase or drive up homocysteine. So you're like, well, shoot, I'm taking a proton pump inhibitor. Wow, what should I be doing? Well, lifestyle modifications can help a ton of people with heartburn or gastric reflux. So what does that look like? Eating earlier, like giving yourself 2 to 3 hours before bed. that you're not eating, smaller meals, keeping your weight managed, having less alcohol, and avoiding any specific food triggers that you know you have. You can also try something you can just like pick up at the drugstore called DGL. It's like deglycerated licorice root extract. Can actually, if you like just, it's chewable, you just chew it up like 20 minutes before you eat, can actually help with some heartburn stuff as well. And finally, the class with the strongest brain harm evidence is this group of medications called anticholinergics, which is a fancy word for medications that block acetylcholine, the brain chemical for memory and cognition. You're like, whoa, why would I want to take one of those CD? Well, things that do this are like Benadryl, right? So for those allergic reactions, or some people try to take Benadryl for sleep, which is a double, like I'd say a double no for that one, especially if you are a high Alzheimer's risk person. Oxybutynin for overactive bladders, older tricyclic antidepressants, paroxetine, Paxil, and some prescription sleep medications also are going to be considered in this group. So the Copeland study in 2019 showed that cumulative exposure to anticholinergic medications over the years is associated with measurably higher dementia risk. All right, so look at your medications, and if you're on a chronic anticholinergic medication, like if you're taking Benadryl for sleep on a regular basis, then we need a different sleep strategy. Okay, if you're on oxybutynin for bladder control, there is a non-anticholinergic alternative that your doctor can swap you to, you might want to ask about. Okay, that concludes medication levers. So at the beginning of this, I mentioned this 2024 Lancet Commission on Dementia Prevention and how they had like a list of modifiable risk factors. And I know if I was you, I would be like, hey, what are those 14 things? So I'm going to hook you up, and this is what they are. So this is their conclusion. Up to 45% of dementia cases could be prevented or delayed by addressing 14 specific factors. And they didn't just tell you basically what to do, they kind of list these 14 out. These are the 14 factors that cumulatively account for up to 45% of dementias. So these are like the negatives. So we want to make them positives for the actual interventions, right? So early on in life, less education early on in life would be, what can we do for that? Make sure that all of our kids, all of our friends' kids have more education early on in life, right? So you get the assignment, make these the opposite. All right, so in midlife, the worst things that you can leave unchecked are hearing loss, high cholesterol, and we know about LDL. Maybe this isn't the best marker here, but like elevated cholesterol, that is going to put you at higher heart disease risk. Depression, untreated depression, traumatic brain injuries, physical inactivity, smoking, hypertension, obesity, excessive alcohol intake, or any alcohol intake. They say excessive though, so I'm gonna go with it. And then later in life, diabetes, social isolation, air pollution, and vision loss. Let's see here. I'm going to address air pollution a little bit more. Let's see here. Right. So let's see here. LDL, depression, and traumatic brain injury, physical activity later in life, vision loss, air pollution. So this is one people like don't think about, right? That's kind of a new one. This is kind of one that we haven't talked about. But living near a highway, exposure to wood smoke, indoor air quality is poor. All of this matters. So air filters in your home are not necessarily a luxury, right? If you think about what to prioritize, air filters in your home can actually be brain protection. Okay. So I wanted to address that specifically because we've talked about more or less everything else on this list. All right, genetics. We're at 1 hour. We have 2 more slides. This is the last slide before we wrap it up. Okay, hang in there with me. So last clinical content slide with genetics, when genetics changes the conversation. The big one here again, ApoE, ApoE4. So specifically, we want to look at that ApoE4. So the master gene here, like ApoE is the gene, and we can have three different kind of situations here. We can either have a 3, a 4, or a 2. Okay, so ApoE, if you're ApoE2, this is actually protective. This is good. This is going to decrease your risk. You could be ApoE2. If you have 2 copies of 2, that's extremely protective, right? So ApoE3 is the most common. You kind of have a neutral baseline risk. And ApoE4 is the risk variant. So you can see all of kind of these combinations you can have here. 3-3, most common baseline risk. 3-4, so that's 1 copy of the risk variant, 2 to 3x Alzheimer's risk. You can have 4-4, which is me. Hi, here we are. 8 to 12 times risk. And again, I've seen some papers quote up to 15 times risk for 2 copies of 4. And then ApoE2. So 2-3 and 2-2 are both protective. So if you carry 1 copy, right? We talked about this. We don't need to go over this. I already said it. Got my notes all here. So what ApoE4 does, right? It is actually, let's see here. It actually kind of controls how your body like moves around and synthesizes cholesterol, which is interesting. It actually increases your risk for heart disease as well. So higher saturated fat sensitivity if you have ApoE4, because you're not going to be able to deal with that as well. Tighter cardiovascular targets. So your ApoB target is going to be lower. We want to target that down lower than a normal person. Your blood pressure target is going to be control earlier, right? Your insulin resistance target is going to be tighter. More aggressive omega-3 supplementation is going to be needed. ApoE4 carriers seem to benefit from higher EPA and DHA intake than non-ApoE4 carriers. Earlier and more aggressive sleep optimization. Sleep is even more protective for ApoE4 carriers, especially if we can get them into some really, really good deep sleep every single night. So earlier consideration of HRT, if you're a woman in the eligible window, the data on HRT and ApoE4 carriers shows particular benefit when started within 10 years of menopause. Tighter alcohol limits, right? I said I personally have elected to just not drink anymore, and this is absolutely the #1 reason why. There are other reasons as well that I just choose not to, but this is definitely the top one. All right. Earlier baseline cognitive testing, even if you have no symptoms, knowing your baseline lets you see changes earlier. And a few other genetics worth talking about. MTHFR variants, right? This affects methylation. Some of you might know about it. Some of you might know you have it. So it's going to affect methylation and homocysteine clearance. If you have these variants I have kind of listed here, then methylated B vitamins work much better than standard B complex. There's also some genes that affect choline and methylation here too that I just did not mention, but those two things kind of do go hand in hand. So BDNF affects brain-derived neurotrophic factor we talked about earlier, and the expression of it and how much your brain responds to exercise. So looking at that can be important. And then COMT affects how you process stress and dopamine. And some people clear these stress hormones slowly and respond differently to chronic stress. So knowing that about yourself can be important. Okay, CYP46A1 affects brain cholesterol clearance, and that's another important one. All right. The big takeaway here, though, is like, hey, ApoE4 can be scary, right? If you know you have ApoE4, You're like, oh my gosh, I'm screwed. But you know what? It doesn't necessarily mean that you will get Alzheimer's. It just means that you have the opportunity, if you know, to work harder on the things that matter and can really move the needle. And multiple studies now show that ApoE4 carriers who address every modifiable risk factor aggressively can have lower lifetime Alzheimer risk than non-carriers who do nothing, right? So that's kind of like one of my missions in life is to do that for myself and to help other people do that as well. All right. So the big thing with this, all of the genetic slides that we go over here is that genetics load the gun, but lifestyle pulls the trigger. So there's always something we can do to risk mitigate us when it comes to these epigenetic SNPs that we have here. Okay, that's what we're talking about. And I can run those for you too. I have my own report that I have built out that is actually excellent, and it's going to give you all of these and more and specific levers to pull so that we can risk mitigate you in all categories of chronic disease. It's got an exercise report, it's got a nutrition report, it's got it all. It's pretty freaking cool. So if you're interested in something like that, just reach out. All right. Clocking in at 1 hour, 6 minutes, and 23 seconds, give or take. That's the deep dive on cognitive decline. Little bit of homework before we leave. First, pull your most recent labs and look to see, hey, do I have a homocysteine on here? Do I have an HSCRP, a fasting insulin, a fasting blood sugar? So I can do that home IR calculation for myself. Is there a B12, vitamin D, omega-3 index? If any of that's missing, that could be, if you're concerned about this or you have a family history, you know, a conversation with your doctor at your next visit. So write down those questions now. Hey, can we add XYZ lab at my next draw? And then second, look at your medication list for any kind of chronic anticholinergic medications, right? Check your medicine cabinet and your daily habits or your nightly habits. Am I doing Benadryl? Do I have oxybutynin or Paxil? Or some older sleep medications, you know, look up and see, is this an anticholinergic medication? If you have been on any of these for years, let's ask your provider maybe about some alternatives, what we can do to eliminate those. And third, pick one risk factor and address it this week. Start now, right? You don't have to start with all of them, but just start with one. Maybe it's getting your hearing tested. Maybe it's eating 40 grams, 30 to 40 grams of protein per meal. Maybe it's cutting alcohol from, you know, back from 8 drinks this week to 4. Maybe it's adding creatine. Maybe it is starting weightlifting 1 time this week, right? Maybe it's getting outside in the morning for 15 minutes in the sunlight. Just pick one that is like something that you think is a low-hanging fruit that you could get an early win with and start forming these habits to prevent Alzheimer's, to prevent cognitive decline, and to protect your brain for the long run, okay? So, homework continued. I want to hear from you guys in Everfit if you're one of my clients, or comment on this YouTube video if you're not a client and you stumbled upon this, and just like tell me what you think. What surprised you the most in this whole presentation, and what's one action that you're going to take to protect yourself for the long haul? All right. And then stay tuned. Next week is part 5, our final class in the chronic disease series. And I cannot freaking wait to see you guys there and wrap this thing up. All right. Thanks for coming, and I will see you guys later. Bye.